Okay, well, it is 12:01, so we are going to go ahead and get started on this cardiology echo session with a focus on hyperlipidemia. Today, our panelists are going to be Dr. Ahmed, who is our pediatric cardiologist, and we have Dr. Michelle Johnson, who is a dietitian who has started working with us in our ETSU outpatient clinic. So between the expertise of these two panel members, we're going to discuss hyperlipidemia, screening for, treatment of, and then we welcome you all to ask us questions that you are not sure what to do with. And I will let Dr. Ahmed get us started.
Okay. Yes. Good morning. Brian, you're going to put the case on, please. And I want to thank whoever put in this case this morning. And I had sort of made up a case very similar to it, but I'm going to go ahead and get started with the case that we have. I don't know the age of this young kid, so I'm just going to presume a young preteen, teenage kid. And typically these are the kids that come to us when they've had their universal lipid profile and it's abnormal. And again, they do not have any cardiovascular symptoms at all. So I get a very brief diet history, and I'm going to leave most of it to Dr. Johnson. Generally poor, though with family with limited insight. Diet is predominantly processed carbohydrates, high in saturated fats and added sugars. Eating pattern worsened after biological parents, I think it's died in an automobile crash, and grandmother wants to give anything to him to just make him feel better. So typically that's sort of it may not be similar to this in all cases, but the diet history is usually quite abnormal. And I would add a little bit of the exercise history too. If this kid is being raised by grandparents, maybe no organized sports, no gym at school. So that's another big concern that we have. He has gained weight ever since he was a young child and in the 95th percentile for his BMI. Why am I concerned about any history of different things? So in the review of systems, I'm looking to blame this hyperlipidemia or hypercholesterolemia secondary to something else. Is it hypothyroidism, diabetes, nephrotic syndrome? And so those are the things I would like to rule out. So if it is, we go to those treatments. In the same area, I also want to look at the medications these drugs are on or not, particularly beta blockers or steroids that can raise our cholesterol levels. And in young teenage girls, we need to think of birth control pills. So anyway, this kid, pre-diabetes for the last 2 years on metformin, and here are the hemoglobin A1C levels. And in this particular child, there was no family history of any premature cardiovascular disease. But in most of our cases, it's usually the mother who's giving us the history. She herself is overweight, obese, metabolic syndrome. I can see xanthomas on her eyes, but then I ask her, do you know your cholesterol level? Basically, they say, no, we haven't seen a physician in a long time, or I have no insurance. But definitely multiple members with diabetes, hypertension, and coronary artery disease. Again, parents do not know their cholesterol levels. History of smoking is important for us. Again, risk factors is what we are looking for. So this child is blood pressure is 114 over 70. Again, I don't know the age, but BMI definitely is elevated. Pretty much the physical exam, when you look at these kids, they're pretty normal. They don't have xanthomas, they don't have acanthosis nigricans. They're, other than them being overweight, obese, and maybe some abdominal obesity, we really don't find anything on their exam. And fasting lipids, basically this is what we are looking for. And again, this probably is on him already being on statin, 5 milligrams twice weekly. So we're going to go over these numbers again, but total cholesterol was 261, triglycerides 238, HDL 35 and LDL 178. I'm sort of going to keep those numbers in mind. Again, LFTs were not done, thyroid functions were not done, but this is something that would be nice for us to have as a baseline test. And typically when a kid like this comes to me, I don't really do an EKG or an echo because that's not needed. There's a lot of talk about this carotid intimal media thickness, and once again, I just want to put it out there saying that in pediatrics, it's not very helpful to look for the carotid plaques in pediatric age group. So this is one of our sort of very typical cases that we have, and these are the cases that as a dietitian, nutritionist, and a cardiologist, we sort of have to tackle this together along with the primary care physicians. Brian, if you can put my slides on. I'm going to keep my presentation quite brief and short, so we'll have some time to talk about nutrition and panel discussion with Dr. Johnson. And so even before I go on with my slides, I want to so I want to thank Dr. Holly Burns. She's our graduating resident who worked with me last year during the Heart Month, which is usually the February month, and did an excellent presentation on kids at risk for atherosclerosis or screening and guidelines for hyperlipidemia in children. So Brian, again, that thing gets, okay. So we can go ahead and get started. So why are we concerned about these kids? As you all know, cardiovascular disease is the leading cause of death in the US. We all know it starts very early in childhood, and it is a progressive disorder. It is a progressive process. Again, we all know there's a lot of genetic, exit. Okay, thank you. Okay, thank you. We know there's a lot of non-modifiable risk factors, the genetics, the race, the gender, the age, but what we are more concerned, or we say equally important or more important, is the modifiable risk factors, which again include a lot of these: abnormal cholesterol levels, the diet, the exercise, blood pressure, diabetes, obesity, and cigarette smoking. Okay, so we all know about this. In fact, I sort of make a picture of this and take it to the kids to show it to them. When we are all born, we have nice, normal-looking arteries, either coronary arteries or carotid arteries. And as we get older, this is going to happen. It is a progressive disorder, the fatty streaks, and then the plaques rupture. And that's when we eventually get into our secondary atherosclerotic disorders, either the heart, the brain, or the kidneys. And again, showing this to them sometimes helps them to realize what's going on, but this is a progressive lesion. And this type of problems has been noted. We do have evidence of it, that atherosclerosis starts early in the childhood. We have number of studies to tell us that, from the young kids who died in the Korean Vietnam War, their autopsies already showed a lot of plaques, so we know it's there. So why are we concerned about it? What are the things that we can do? Before we go into the treatment, I want to let you guys know that cholesterol levels are not constant. They can change. Up to 2 years of age, it sort of continues to increase some. And around 9 to 11 years of age is actually the highest mean cholesterol levels. And that's sort of the age when we do our universal screening. So that is the age group that we always think about for universal screening. But do we want to screen any other high-risk group kids before that? So again, typically we do not screen any kid for a lipid profile less than 2 years of age because the numbers are still rising. What about kids between 2 and 10 years of age? These are the high risk group. So if you have a kid with all these other comorbid findings, overweight, obesity, hypertension, diabetes, or if you have a significant family history, or sometimes you don't have a family history, yes, we can screen their cholesterol levels between 2 and 10 years. But typically, we do it around 9 to 10, 11 years of age. And again, it is a universal screening now. And one more time, we sort of do it between 7 and 21 years. Between this age group, we do not do it because there may be some changes in the lipid profile unless it's abnormal. I always like a fasting level just because if it's non-fasting, then we sort of blame it on the diet. So I might as well get a fasting level to be sure what's going on. Again, it can be done with a finger prick. So how often do we screen? Again, universal screening, 9 to 11 years of age. If it is abnormal, we have to recheck it again within a few weeks. If it is normal, recheck it again in 3 to 5 years, or again go into your 17 to 21 age group. So that's sort of simple to remember the screening for kids looking for hyperlipidemia or hypercholesterolemia. So when you get your cholesterol levels, what are the numbers sort of to keep in mind? There are a few numbers, but it's not that confusing. Let me sort of go out here. HDL, that's the good cholesterol, less than 35 is abnormal. Triglycerides greater than 150 is abnormal. So these two numbers, 35 and 150. So those are for the HDL and your triglyceride. So when you come up to this table, let's talk about the total cholesterol and LDL. Again, a lot of numbers, but not too hard to remember. Anything above 200 is abnormal, less than 170 is normal. This is for total cholesterol, so 200, 170. LDL numbers, anything above 130 is abnormal, less than 110 is normal. So again, these are the numbers, 200, 170, 130, and 110. Okay, those are just the few numbers that we sort of want to remember. So the treatment for hyperlipidemia, hypercholesterolemia, again, basically it is a population approach. Basically, it is modifying the risk factors that we can modify, which is based on our diet and exercise. So when those approaches don't help you with getting your cholesterol level back to your normal, that's when we go into our individual approach, but making sure they've had a dietitian input at least for 6 months before we put them on any medication. So what medication and when? So again, this is a number to remember. Kids less than 8 years of age, we typically don't put them on any medication unless the LDL is significantly elevated, or they have really high, or they're in the really high risk groups, diabetes, kidney disease, heart transplants, or kids with Kawasaki's disease and aneurysms. But typically it's the 8 years and older. So once again, 8 years and older are the ones that we treat with cholesterol lowering drugs. So what numbers do you need to remember to see which are the kids who are, or when is it indicated for these kids to get their statins? Statins is the first line of drug. We used to use bile acid sequestrants and all that, but no more. We go straight to statins. So once again, for our recommended treatment for abnormal cholesterol levels, we are not going with the total cholesterol. Just keep this in mind, LDL cholesterol, LDL. So again, make sure this diet therapy has been done. They have to be referred to a dietitian at least for 6 months. They've stuck to their diet. So if you have no other risk factors, the kid is not obese, no diabetes, LDL has to be over 170 before we put them on statins. So this is LDL, not total cholesterol. If you have a kid with other risk factors, obesity, hypertension, positive family history, we take a lower LDL level, so anything greater than 160. Children with diabetes, we lower the LDL some more. So once again, in most of our kids, it has to be quite high before we put them on medication. 190 with any risk factors, 160, diabetes, again 130. Again, look, diet therapy is one of our mainstay with our treatment of this. I'm not going to go too much into all these medications. Again, bile sequestrants, cholesterol absorption drugs, we don't use it anymore. We go straight to statins. And the case that we had here, I'm not going to go any too much details into the medication because I want to sort of give Dr. Johnson some time for her to discuss. Again, with this kid, he was overweight. BMI was 99. He was pre-diabetic. His cholesterol levels were quite abnormal. Again, these lipid levels that we have here may be on the statin itself, and we haven't really reached the goal. Typically, we like to get the LDL between 130 or less than 130. So we have, if he has not had any side effects, myalgias from the medication, if his labs are looking normal, there is more room for us to go up on the statins because we have not reached our goal. But again, along with the medication, I always say it's important to continue your nutrition. And I sort of end up with most of my kids saying that you only have to exercise on the days you eat. So towards the end, so I asked the kids, so how many days a week do you have to exercise? So I leave it there and give Dr. Johnson her chance to talk a little bit about it and see if we can use what can help us with in our office setting.
Okay, so there are some handouts that we've created for the lab, for the clinic itself, and I'll come back to these. I believe, did you have other slides that I sent to Linda? Okay, well, it's no big deal. Okay. If you'll go back to those, and I can just talk to what I had sent the other day, and a lot of it kind of mirrors what we just heard. And from the nutrition perspective, we look at nutrition indicators for risk, a family history, hypertension, obesity, as we were talking about, diabetes, a diet that's rich in saturated and trans fats. And this child, we'll talk a little bit about their diet and how that really is something that we're noticing. Certainly excessive energy intake. We talked physical inactivity and cigarette smoking, and these are all indicators that I would look for to see if someone was at risk, even outside of receiving a referral, to talk with someone, because we do know that nutrition intervention is recommended. Some of the other things that we look at kind of, again, align with this, and we talked about that, some of the lab values, the family history, secondary dyslipidemias, obesity, chronic renal disease, and nephrotic syndrome, and again, diabetes is a big piece of that. From the nutrition standpoint, typically we would look at the lab data, again, the diet and lifestyle, and then based on what we typically will see, a diet high in processed foods, a diet high in saturated fats, low in fruits and vegetables. We'll try to kind of create an individualized approach for that particular child and look at their physical activity as well. And I do feel like from the nutrition standpoint, we do discuss physical activity, even though it's, slightly out of our scope, and some of us are more knowledgeable about it than others, but we do certainly include that. So if we can go back to those slides, I'm sorry. So some of the handouts that we use in the clinic now, you're going to pull those right back up. We have them kind of designed based on the education level of the family, and also perhaps a little bit more of the age of the child. So this first one was just kind of a fun infographic that we put together to use for kids and families. We find they don't tend to read wordy, as many of the wordy handouts that we like. We like to give lots and lots of information, but this is more of a, some of these handouts are a little bit more of a, we like to call them like you'd hang it on your refrigerator and use it. And so these are the big aspects, especially for a very young child. Things like eating more fruits, vegetables, fish, healthy fish, whole grains, encouraging skim or 1% milk, no fat, non-fat, and 1% milk. And all children over the age of 1, there seems to be no real benefit to continuing the fat content of milk as far as the evidence that we've seen is concerned. So promoting skim or 1% milk. Eating less of the fast foods, fried foods, processed foods, things like, processed meat. Also encouraging them to drink lots of water, getting up and being active. And this handout is kind of nice. We like to individualize every education. And so based on that child, what are their particular nutrition goals? And so, a lot of our kids are eating school foods, and so we don't have a lot of control over that. And so outside of that, perhaps they're eating pepperoni pizza. We go, talk about limiting some of those processed meats and maybe switching to maybe cheese pizza and making attainable small short-term goals that we can kind of reassess as we go. Activity goals, of course, 60 minutes a day, and trying to really figure out that child's social situation and life situation at home, and really choosing activity goals that relate to that child and are appropriate for that child. We have a little bit more, we have another handout that's a little bit more extensive, and it has a lot of the same information, but it just gives you a lot more detail about it, talking about reducing the child's cholesterol, the importance of it, receiving medical treatment, prioritizing activity, making diet changes. And this is sort of the three-pronged approach that we take every time we educate a child about any health-related issue. Again, this is kind of the second part to that more extensive handout. And again, we always include those individualized nutrition goals and activity goals for each child. So I like to include those. Being active, making it family time. I really like to talk to the families about what they're doing as a whole. As we know, without the support of the family, a child cannot be successful. And we hear a lot of, well, we're not really good about this, but we try to really encourage, the child to be better about not eating sweets or not eating chips, but yet there's still lots of chips and lots of sweets in the house. And I try to use the example of, what's your favorite food? And if they say, I don't know, French fries, and say, if we had French fries in your house, would you be able to control yourself? And then you have to talk about that in terms of a young child and how they don't have as much of a self-efficacy as far as being in control of their own eating patterns, making sure that we're getting the family engaged. Eating healthy, and again, it has lots of tips for fruits and veggies, encouraging all types of fruits and veggies. If they need to do canned, that's fine, as long as they're doing a lower sodium. Frozen, we encourage frozen fruits and veggies because we don't want waste and economics to be an issue. And then talking about some of the cooking tips as well. One of the things I focus on a lot is fast food, and a lot of our kids are eating fast food. Some of them daily. So looking at what they're choosing at fast food restaurants. And I like to even go more practical. And if their family is going to a fast food restaurant once a week, okay, what are some better choices on that menu versus, trying to say, you guys just can't do fast food at all. And then really focusing on their beverages, sipping smart, making sure that they're not choosing sugary drinks, soda, fruit juice, those sorts of things, and making sure that they're understanding and being very thoughtful about those things. And then we like to follow up fairly regularly. We may not have a new cholesterol level or no new lipid panel, but we can monitor the weight and making sure that the weight goals kind of align with the overall health goals. else, and I was trying to think if there's anything else specifically. We talked a little bit about plant phenols, and there are some more natural phenols, plant phenol esters, things like olive oil, natural corn oil, beans, encouraging things like nut butters, almonds, oranges, apples, those kinds of things, but also perhaps encouraging, if it's within their budget, some of the modified foods that are available on the market that actually contain some of those plant phenols as well, like the spreads, the buttery spreads that are a little bit healthier. I usually limit those more to adults than kids because they're not as much of a use. We definitely want to modify have a fat modified diet. We educate about cholesterol and what foods cholesterol are in, increasing fiber and plant fiber, making sure they're getting more soluble fiber in their diet, looking at snacks, and then just overall making sure they have a healthy diet, a general healthy diet, and increasing that exercise. All of those things, just the easy stuff, the easy changes.
And we were talking about it the other day. You don't go too much into the recall diet history anymore, or is that something that I should say before you go see a dietitian? Keep a list of what things you're eating, or
well, we found that keeping like a 3-day food diary is not always entirely accurate, and we may be able to get as good of a picture in a 5 to 10 minute interview about what they're eating. And I can say, what do you usually eat for breakfast? What is your typical? Tell me what you ate yesterday for lunch. And within about 10 minutes, I can get a good picture of what their overall diet is. Even a 3-day food diary is very specific to that 3-day time frame. And it could be that it was a holiday. It could be that it was a weekend day and they eat very differently. One of the biggest challenges that I run into is the kids who are dependent on school foods for their nutrition for breakfast and lunch. And I'm finding it challenging to give them good tips about what to choose when their choices are fairly limited. So that's one of my goals for the next few months, is to touch base with them and see what we can do to at least provide some sort of convenient / still healthy food, particularly at the high school. And that seems to be our biggest limitation there. But yes, a 3-day food diary is rarely accurate, I'm finding. And so, in fact, sometimes if someone says, I want you to put me on a diet, I'll say, you bring me your 3-day food diary, because that will let me know if they're really dedicated to whether or not they're going to spend that time. Keeping a food record is tough, and particularly with different education levels, which I'm running into. And the parents may not know what the kids are eating at school. Honestly, they get to choose their own. So, kind of doing the big picture, really doing it, looking at each patient individually is really the key piece of it, I think. In particular to that patient, and we're going to talk a little bit about that particular patient.
The kid on the case study. Is there any, again, from my standpoint on the medication, I would make sure that I, depending on how long the kid's been on this medication, if I need to get another repeat fasting lipid profile, I would also get a comprehensive metabolic panel to make sure my LFTs are normal and the alkaline phosphatase and creatine kinase are normal. And if he or she has not had any side effects from this medication, there's plenty of room to go up on this one before we add something else to it. And again, continuing to keep their diet going, because a lot of the times if they know they're on a medication, they sort of relax on the other part of the treatment.
Absolutely. And I was going to say the other piece of that was the family dynamic here, and that's the piece we didn't talk about too much, is the death of the parents. And it may be, at least we're lucky in our clinic situation where we have access to behavioral health and other professionals that can come together and maybe take that interprofessional approach to talking about other strategies to address the feelings, not eating to address feelings, but maybe using some other strategies to address that loss and not using food as a coping mechanism, which is, as we all know, is a tough one to overcome. So really talking with grandma and talking to her about some other really better strategies for, making decisions about foods would definitely be a priority for me on that.
Does anyone have any questions for our panel?
Yeah, this is Mark. I have a couple questions. My first question is related to the universal screening, and you talked about the two age groups that you target. Are you targeting all children at those age groups, or are you targeting children with certain risk factors, certain BMI or family history, or is it all children?
It is all children at this point. And in fact, there was an article that came out just recently or just a few years ago. It's not just the high-risk groups that we find that their cholesterol levels are abnormal. It's like even if you don't have those non-modifiable genetic issues, you still can have. So at this point, it's all kids that we are trying to get to.
At the 9 to 11.
9 to, right, yes, at the
11.
9 to 11 age group, that's correct, yes.
And is this something that TennCare pays for?
By the time they come to me, I already have an abnormal level. So,
Yes, I do believe they will. We have been, at least from our lab, we have been able to be reimbursed from it.
Okay. So one more, just expressing an observation, and this is towards the dietitian. When you talk about in your pamphlets, you have highlighted the foods that you encourage, your low fat proteins and your complex carbohydrates, and then when you look at the food pyramid, its foundation is very heavy on the carbohydrate side. Do you think that's confusing to people who look at it and see that, oh, they should be getting more carbohydrates, but we're talking about more complex carbohydrates versus the sugars that we want them to stay away from? Just a thought.
No, I understand. I think that and it's hard to see on there, the title of that one is really specifically focused on fat. So that little diagram, it is, yes, and this, there's a lot of debate about the AMDRs and whether or not they're a little carb heavy in general, but I think that would just be about addressing that, what those healthy carbohydrates are, because we don't want people to be afraid of the carbohydrates, because in essence that, it is truly the foundation. But I think the title of that graphic is keep less than 30% of your intake from fat, and so it can be confusing. If we need to kind of adjust that, that might be something to think about.
Sure.
But really just pushing complex carbohydrates, talking about fiber, and really, that it's just a matter of addressing it with them and explaining that as part of the overall plan. But we don't want them to go protein heavy either. So it's kind of like, that's a tough one. I can see confusion, but we just really try to spend a lot of time educating each individual child and family about what healthy carbohydrates would be versus highly processed, refined sugars and that sort of thing.
I'm really surprised at how poor the school diets are when I talk to my preteens and my younger patients. When they talk about the vegetables they're offered, and they're usually used to be a potato in some form or another. How do we have an impact on that? And can we, you talk about you're working on that in the future. I don't even know who sets those mandates, so to speak. I don't know if you had any insight into that.
Right. So the restrictions for the food service, the mandates got more restrictive within the last 6 years. I think as recently as this past month, they've rolled some of those back a little, so it's a little less restrictive, at least from the sodium perspective. I know that they were going to go even more restrictive with sodium. The issue with the school food service is there's no funding, so they have no employees. And what happens with that is that because they have no employees, they have to go with, frozen heat and eat type of foods. And so all of these big food companies promote, okay, it's at least 50% whole grain, but there's still Pop-Tarts with 400 calories and 10 grams of saturated fat. But from the USDA's perspective, the restriction is only that at least half the grains have to be whole grains. And so if they can squeeze whole grain into the title, it's kind of like, you know, Fruit Loops. My daughter loves Fruit Loops, and they're whole grain as well, but it's not something that has any other nutritional value truly to it. Yeah, it's the biggest challenge, and it's not the school's fault, certainly.
Right.
I will say that when in 2011, when these new regulations came in, that I spent a lot of time with one particular county in this area, and we redid the foods and, you know, created this really great variable menu, and the parents had a fit. They went to the newspaper, they caused a ruckus, and so that county reverted to their previous menus.
Wow.
And so it's really been a challenge. It's not really the children as much as it is the regulations, and it's really more budgetary, unfortunately. And so they have their hands tied because they have to really go with a lot of this heat and eat food. So one of the things with the breakfast, this is new. At least in Johnson City, they created this breakfast cart, and so they kind of use it to catch the kids who didn't either make it to the cafeteria for free breakfast, or maybe they were embarrassed to be participating, you know, because there's a lot of social stigma around free and reduced lunches. And so they've created this breakfast cart, and so it rolls through the halls, but there's not a heating element there really. There's not, you know, so it's, you know, Pop-Tarts, very cinnamon rolls, things that are portable but not healthy. And so that's where I'm hoping to get in touch with the school food service director here in this county and see if we can even just add one thing to the breakfast cart that's an option that I could say to the kids that I'm counseling on a regular basis who cannot afford to buy breakfast and pack their own lunch. Okay, well, I know there's one option on the breakfast cart, you know, try this breakfast burrito or whatever it is. But then they have to take it and they have to eat it. So it's kind of that challenge. I do not envy food service directors in the school food service system. I would not want that.
No, it's not only just the school lunches, it's the vending machines that's there too. And on a personal note, we used to have tons of money on my daughter's account at school, and every few days it was gone, and we used to pack lunch for her. And we realized that she was eating 2-3 ice creams per day. So the kids too, and nobody tells them not to do it. And I had a young kid with supraventricular tachycardia who would take 3-4 cartons of chocolate. So there should be something there that we need to tell them they should not be allowed. I know you said the children is not the children are the ones who want.
Well, the teen, you know, and you know, it goes back to teaching them very young, and if we can target, you know, as they're coming up. I'm always amazed at the lack of nutrition education for family. I think I'm shocked. I tell my students all the time, I'm shocked on a daily basis of what people don't really understand about how, you know, fried foods are not healthy. Fast food is not a good choice. And it's really, you know, I had a patient the other day whose daughter was drinking Capri Sun rushing water variety. And I said, oh, well, can we maybe do waters? And they had switched to that because they thought it was a healthier version of a juice because it said water on the title. I mean, it's really very, it's concerning. There's a lack of education from even the more systemic level. But from what I can do in the clinic is work with each family individually and try to just kind of provide some of that education, some real attainable goals versus like saying, no more fried food. Well, you know, that's maybe not the, you know, we don't want them to become frustrated and overwhelmed either. So making those attainable goals and making it certainly individualized to that particular family is important. I'll tackle the school food service thing. That's next on my agenda. They're going to say, no, leave me alone. They may not return my phone calls. Who knows?
But education, again, I realized that, and I know I did it a few years ago when my kids were still in school. After getting permission from the school board, I took a human heart specimen, a baby's one and an adult one, to show them the difference, how much of fat gets onto your heart. But I hope I got some message through, but at the end of the day, all the pictures of it, the human heart was on the Facebook on those kids. But I do hope they got something out of it. So yes, education is key. It's a big thing.
I do have one more question. If you could speak to starting doses of the statins, and then follow up, you mentioned LFTs, but
Yes.
is the same risk for LFTs and muscle breakdown and those types of things?
Yes, it is. So the ones that we sort of use is more go with Pravachol or Pravastatin. Use it at 5 to 10 milligrams per day at nighttime. And again, it all depends on how the kids are doing. Start off with a very low dose and gradually go up to get to a goal of LDL close to 130 is how we look at it. As long as they're not having any issues, myalgias, we can continue to keep going up on the medication till we get our goal, as long as all our other labs are fine. So how frequently do we repeat labs? 4 to 12 weeks is the recommendations given to us when we are starting medication or changing the dose of the medication.
Okay.
And if they have side effects from the medication, we stop statins, start off with the lower dose of another statin, and then gradually go up to see if they will do better with this particular statin.
Okay.
And would you do anything different for patients with markedly elevated triglycerides?
I know that's sort of, from my standpoint, I sort of say unless it gets to about 400, 500, abdominal pain, pancreatitis, I really do not have a whole lot to help them with other than diet and exercise and diet and exercise. The other than triglycerides, HDL is a big one. It's like we have so many HDLs in kids in the 20s and 30s, and there's no pill there to get that HDL or the good cholesterol out. Exercise is the only pill we have. So yes, triglycerides is a concern more in the diabetics, and so I don't deal as much with just that. So.
And that brings up another, the other thing that we come in contact with is from the physical activity standpoint is a lot of the, screen time. And I think even the regulations on that have changed recently, or the recommendations on that may have changed slightly. But what we try to do is find some apps that have some fun exercise related activity. And the kids are on their phone constantly. So we're trying to figure out ways to find a fun app that has some, and I have a list that one of my grad students pulled together for me because she's more savvy than I with the apps. But just trying to find something, that they can relate to from an activity standpoint, because as you said, the HDL activity is the only real strategy that we have other than, just overall healthy eating, overall health.
And I would say there's a fair amount of confusion in nutrition science about are dietary fats necessarily responsible for elevating cholesterol in the blood? And then we've gone from eggs are bad to eggs are good, and fat-free to fat is good, to low-fat dairy, to now there's some studies saying children who have high-fat dairy actually weigh less. How do you sort through the nutrition news and help recommend choices and educate parents?
What I try to do is just focus on saturated fat and helping, trying to encourage them to limit the saturated fats, the fatty meat, the fried foods, and those sorts of things that are going to increase, we know, overall are increasing the risk for heart health or heart disease, increasing the bad cholesterol, if you will, and then trying to encourage them to eat more of the healthy fats, and it does get confusing. And I can imagine from, it's confusing for us, and then recently, you can't really affect your cholesterol with your diet, but you can, and which we still do, I still think that a really poor diet is going to affect your cholesterol in some way. Whether or not it is the major factor that affects it versus genetics, I'm not sure, but yeah, that I can see where that's really confusing. A lot of the, you know, we don't do a lot of discussions as much with kids as we do with adults around cholesterol, which is, I think, going to change. It's amazing to me, you know, like you said, there's a greater number of children out there with high cholesterol than we would have ever imagined. And so just kind of being able to pick the ones who are at the highest risk and kind of, you know, sort of educate them. And it's such a huge prospect. Thinking about school food, thinking about home, just trying to address it on all aspects that you're right now.
And I guess my last thought or question is, I feel like now sugar has become public enemy #1. It used to be fats, and I feel like sugar has taken its place. What do you feel like the role of sugar has for these kids who have elevated cholesterol, triglycerides, and is it pro-inflammatory, and is just as much contributing to plaques in the arteries and coronary artery disease? What role does sugar limitation have for these families?
I think there's certainly a link between sugars and triglycerides, but also just excess energy intake overall. And so the more sugar, you know, we talk in terms of empty calories versus, you know, excess energy is going to lead to excess fat storage, which then in turn is going to lead as well to higher risk of cholesterol. But sugar specifically is not, you know, a bad thing. It certainly is not the fat that we think would be as detrimental to those lab values. But if you increase the triglyceride levels, then you're going to also see kind of negative results from that. But really, I would say from an excess energy intake perspective overall. And is that replacing what could be healthier food? So just thinking about it in terms of making those better choices.
Are there any other thoughts or questions from the folks who've joined us? All right. Well, thank you for joining us. Our next session is February. Dr. Anand Wattaj, or just Dr. Wattaj, is going to be talking to us about hypertension, and Dr. Johnson will be joining us as well. So if you have any cases with hypertension or anything along those lines, go ahead and submit those. We'll be sending out an email with the case submission forms probably in the next few weeks so that you have an opportunity to submit those cases. We'll let you know about the February date. Does anyone know offhand? February 20 something. That will be in the email as well. So join us. We were glad you were here today. February 20th is what I have on my calendar. So February 20th, 12 to 1. Join us again. Submit your cases. And if you have other ideas for topics or themes, let us know. We always love to hear from you. And if you want CME credits, submit your evaluation form after this session. Thank you all.
Thank you.
Smoke is a big thing for the email it. Just come. I know one of my kids. Guess I don't. Shunt dependence. Issues with setting. The minute this kid walks in, you can smell the smell.